All right. Good morning, everyone. It's 10 a.m. and we're going to go ahead and get started. We've got a lot of great presentations today. My name is Alyssa Strackbine, and I'm the Operations Manager for the Appendix Cancer PMP Research Foundation. I'm so pleased to welcome you all to the 2025 Virtual Multi-Regional Appendix Cancer Symposium. We're thrilled to have almost 500 registrations this year, including physicians, other healthcare professionals, patients, caregivers, and supporters from over 30 countries around the world. On behalf of ACPMP, I want to thank our planning committee, our moderators, Doctors Levine, Lambert, and Taraga, and of course, all of our presenters for sharing their time and expertise today. Before we begin, with just a few quick housekeeping notes. All lines, participant lines are muted to reduce background noise. Please submit your questions using the Q&A button at the bottom of your screen throughout the session as you have questions. We also received a ton of great questions during registration, so we're going to try to get to as many as possible. There will be 3 Q&A sessions during today's program. With that, I'm excited to introduce the moderator of our first session for Part 1, Education and Fundamentals. Dr. Edward Levine is a surgical oncologist at Atrium Health Levine Cancer and professor of surgery and chief of the surgical oncology service at Wake Forest University School of Medicine. He joined the faculty at Wake Forest in 1998 after being a faculty member at LSU New Orleans for 6 years. And his general surgery training was at Michael Reese Hospital in Chicago, followed by a surgical oncology fellowship at the University of Illinois. He was promoted to professor and chief of surgical oncology in 2002 and is the founding director of the Surgical Oncology Clinics, chair of the Hospital Cancer Committees, deputy director of the Oncology Service, site PI for the NRG, and medical director for oncology optimization at the Wake Forest Cancer Center. I also forgot to mention that this will be recorded, so all sessions will be available after the event. We're so honored to have you with us, Dr. Levine. Please take it away.
Good morning, everyone. Welcome, welcome, and welcome again. It is absolutely a pleasure to welcome everyone to the 2025 Annual Appendix Cancer Symposium. This is something that's been our pleasure to put on for some years. This is supported strongly by the ACPMP, as well as my co-directors, Dr. Kiran Taraga from Yale and Dr. Laura Lambert from the University of Utah. So this morning we're going to be starting out with what I call the 101 talk in terms of the basic introduction for people who may not be quite as familiar with cancer of the appendix, so to get you oriented in terms of what we're talking about. That's going to be followed up by a number of other sessions. The first one is going to be moving on to what we call a tumor board. A lot of people don't know what a tumor board is. You're going to see how they work and what they actually look like. We're going to take you through them with representatives of surgical oncology, medical oncology, radiology, pathology, et cetera, all putting their best opinions forward for the benefit for patients. And this is what we do on a regular basis at most large cancer centers. After that, we're going to be moving on to where we are in terms of state of the art, grant reviews, where we're going. And the afternoon, there's going to be regional symposia for each one of the lead centers in this symposium. So this is who I am, and I live in North Carolina at beautiful Wake Forest University. And this is the talk on cancer of the appendix, really, pseudomyxoma, and again, the 101 class. The first thing I wanted to say is that for patients who are new to this diagnosis, you are not alone. This is a rare lesion, a rare tumor, almost literally 1 in a million, but you're amongst friends today, and we are going to see what we do to make you not feel so alone. And I think by the end of the symposium, hopefully you'll no longer feel quite so isolated if you do. Now let's get started. So appendiceal tumors, they are rare lesions. These are some numbers in terms of how many tumors we see of different types: lung cancer, breast cancer, colon cancer. Way at the bottom is appendix cancer, which is in a range of about 3,500 cases a year. Now, we live in a country of close to 330 million. So, this is a pretty rare diagnosis. It's also noteworthy that the NIH, which is the main government group which allots research grants, allots them by and large by incidence. So if you look at the incidence of appendiceal cancer, not surprising, we don't see too many research awards given to them. I think there's only been 2 to date. We have both of them here at Wake Forest, I'm proud to say. But the point is, it's important to support appendix cancer research. The ACPMP does a great job with that. You'll hear more about opportunities for that a little bit later in the morning. Now, everybody knows someone who's had an appendectomy. There's more than 500,000 which are done a year. And in general, we're going to find tumors in about 1% of the appendectomy specimens that we take out. Very few of these are done on people who we knew about the tumor ahead of time. Now, this was first reported, appendiceal tumors, over a century ago. And less than half the time, even holding the appendix in your hand at the time of surgery, do you realize what it is or that there's a tumor in there. This is one gastrointestinal tumor in 200. It's a rare, unusual finding. The average general surgeon in practice will encounter 2 of these in a career. The surgeons you're going to be talking to today will usually talk to people who have 2 of these every hour. So again, the experience tends to be pretty concentrated in specialized center. What we find is when people have an appendectomy, which is usually, again, appendicitis, you'll come in with usually right lower quadrant pain, fevers, nausea, elevated white count, et cetera, et cetera. So the appendix comes out, which we actually find, and we reviewed close to 500 people who had appendectomies, had tumors in them, that very few of them actually evaluate whether there's tumor in the abdomen. Most of the time, the surgeon doing the procedure doesn't know it's there. And actually finding descriptions of whether the tumor has spread anywhere is relatively unusual, only about 7%. What's more, if you have your appendix out of community pathology or a community hospital, the pathologist will rarely encounter these, and the pathology reports can be incorrect, probably close to 1 time in 4. Again, you need to get yourself to an expert center. Now, appendix cancer is not something we screen for. The incidence is too low for a screening program, much like we have screening programs for colon cancer, but not really for appendiceal tumor. And if you have an endoscopy, you'll only find an appendix cancer if it's present about 1 time in 30, about 3% of the time. Now, you find polyps 40% of the time. So if you are found to have one of these tumors, you want to get your colon checked out to make sure you're doing anything else before any other treatment goes ahead. But patients come to me regularly, say, "Oh, gee, I just had a colonoscopy, they didn't see it. Did the GI doctor miss it?" And the answer is no, probably not. It's just not someplace. The appendix has got too small a lumen or center in it for them to drive the scope into. So they'll rarely see it, even if it's present. Now, this is a slide I like to put in because we're going to start showing some pictures of actual tumors. If you are a more sensitive viewer, you might want to look away from the screen and just listen. Not that what we have is particularly gross. But just so you know, I don't want to scare anybody as we start actually looking at tumors. So this is a picture on the right side of the screen. It's actually a tumor, something called frosted appearance. You'll see that on occasion. Again, appendiceal tumors, most of them we find are benign. They're usually incidental to an appendicitis or having your appendix out. And there's a variety of them, and you're going to see some letters up there. Benign tumors called a Lamin or Hammond, H-A-M-N-L-A-M-N. That's low-grade appendiceal mucinous neoplasm is what that actually stands for, or high-grade appendiceal mucinous neoplasm. One thing to note, high-grade appendiceal mucinous neoplasm is technically a benign tumor. It looks nastier than the low-grade, but it's not actually a cancer, technically speaking. It can spread, but you'll see these sort of letters put on pathology reports pretty frequently. Now, if that's all you have and the tumor hasn't ruptured and the margins are clear, just taking the appendix out is curative. Unfortunately, we frequently find tumors when they've spread far beyond this stage. And usually I put up there, people like to know if somebody famous had this diagnosis. And for those of you who are history buffs, Dan Quayle was vice president 30 years ago. He had his appendix out while he was in office, and he had a benign tumor, which was a benign appendiceal neoplasm. What we're really here to talk about today is more of the malignant variety or the metastatic variety. It turns out the most common tumor in the appendix is still something called a carcinoid tumor, which is something I've only got one other slide on. That's really not the focus of our talk today. Carcinoid tumors and adenocarcinomas and the Levine-Hammond tumors are totally different beasts. Their rules of engagement are very different, how they spread are different, how they respond to treatment are different. Most of the time, we're going to find the adenocarcinoma or the Levine-Hammond tumors. There's some other rare types. And one of the things I need to warn you about is if you start looking for pathology reports, particularly if you start looking in the literature, the older pathology reports and schema were very confusing. The pathology was not unified till relatively recently, and even now, some pathology departments are still using older classification systems, which can confuse things quite a bit. So you need to be careful when you read the pathology reports because they are easily confused, and the farther back you go in time, the more confusing it becomes. And one thing we can say about appendiceal tumors is they're becoming more frequent, more common. So the incidence is increasing. What I've shown you is you've got 3 graphs here, which show data over basically 40 years, showing that we're seeing more and more appendiceal tumors. Now, why that is, I do not know. I suspect it's because more pathologists know what some of these appendiceal tumors look like, and they're calling it more frequently on the final pathology. But we're seeing more of them than we used to, so the incidence is clearly increasing. Another question I get all the time is, are the appendiceal tumors inheritable? Are they genetic? So most people know of breast cancer, ovarian cancer, which can go generation to generation to generation. The answer is no. These are 2 separate research papers looking at 237, 131 patients. They both reached the same conclusions, looking at 14 or 90 different inheritable genes in the 2 manuscripts. What they found is about 10% of patients have, in a series of up to 90 different genes, some sort of an inheritable mutation. Most of them are not what we call germline variants. There's no clear driver gene that you can inherit for appendiceal cancer. There are a few, but there are no clear driver genes. So routine screening for germline variants is not currently warranted all the time. So people choose to undergo it, which is a reasonable thing to do. It's basically a blood test. But this is one of those questions that you hear about all the time. So people are usually worried about, are my kids going to get this? And the answer is usually no. Next question is pseudomyxoma peritonei. What the heck is it? It was first described 140 years ago. And it's really a syndrome of mucinous societies. And if you look on the right side of the screen, they were opening up somebody there at the time of cytoreductive surgery. And what you see is the material in there, it's actually mucus, much like you see when you sneeze. And what you have is the tumor from within the appendix being produced outside. So the jobs of some of the cells on the inside lining of the appendix is to produce mucus, which sounds kind of gross, but mucus is really the lube that helps food move through our guts. Humans are completely dependent upon it. We have to have it. Now, if the mucus is in the gut, it's digested and recycled in a very elegant system. But if you have a tumor that ruptures and the mucus producing cells get outside of the appendix, the peritoneal cavity, the inside lining of the abdomen, has got no way to absorb it or get rid of it. So it tends to just accumulate. These can come from low-grade or high-grade tumors. And if you don't treat it at all, the chance of making 5 years is only about 1 in 10. So clearly we want to intervene and keep people from having bad outcomes. The other thing to remember is removing the mucin is not curative. It's the cells that are producing the mucin that's the problem. Mucin is a byproduct. So the key to treatment is to remove the tumor. Yes, you want to take the mucin out too, but the key is to remove the tumor. And again, what most people die of if you don't treat this is usually a bowel obstruction. This is my only slide on carcinoids. Again, significant portion of the tumors in the appendix, 40% of all carcinoids, and you can get carcinoids anywhere in the GI tract and in some other places as well. The tumors are very different. They do not respond to the HIPEC that we'll talk about later. Carcinoids never lead to the pseudomyxoma syndromes. They may be candidates for aggressive surgery if the tumor has spread. If the tumor is not spread out of the appendix, frequently just taking the appendix or the right part of the colon that the appendix hangs off of out is sufficient. So we're not going to talk about carcinoid, I think, any further than this slide, but again, something you need to know about. So let's shift into the main focus of the symposium, which is appendiceal tumors. And I put up some pictures of some famous people so people know who actually had this disease, and some famous people died of it. Audrey Hepburn, famous actress, and actually quite the humanitarian. And Stuart Scott, famous sportscaster, who actually has got a terrific quote there I recommend to you. So this is rare. And again, for surgeons who might be watching in the group, if you find this unexpectedly, take out the appendix if it's perforated, check some tumor markers when you're in there doing the operation, describe where the tumor is and where it isn't. Do not open additional planes. Don't take everything out. Stop, put your pencils down, send the patient to an experienced referral center. Again, it's about 3,500 cases a year, and frequently find these ruptured or spread. Unfortunately, frequently, most of these patients are going to present with tumor which is already spread. So if you open up a textbook of cancer surgery, it means stage 4. Right, again, even if you see stage 4 on your reports, that doesn't mean hopeless by any stretch of the imagination. We still have got a lot to do. Now, what do we do when we find one of these? Look for additional primary tumors. Appendiceal cancers can have those. We're going to check, there's some blood tests that we checked, some tumor markers, CEA, CA19-9, CA125. These are 3 glycoproteins that circulate in the blood, which can correlate roughly with the amount of tumor in the abdomen. There's also blood draws or liquid biopsies and circulating tumor DNA, which is currently being looked at. And I think that's probably something more for the future. The prognosis is clearly related to grade. You'll hear me say that multiple times through the rest of the talk. The risk of nodal disease is clearly related to the grade, and there's several pathologic descriptors. Beware of pathology. If it's a low-grade tumor and the margin's negative with the appendix, all you need is an appendectomy. If it's a high-grade tumor, we usually recommend taking the right colon out so we can take the lymph nodes out with it. There are multiple pathologic systems which can describe exactly how the tumors look under the microscope. You got 3 pictures there at the top on the right side of the screen is what one of these tumors looks like when you find it in situ. There's a low-grade tumor, and it looks more or less like normal cells with some tumor in it. They're not normal, but they look more like normal cells. And at the bottom, you see just a few cells, and those spaces in between the pink stuff, that's mucin. So that's mucin being produced that's floating out between the cells, floating apart. That's a high-grade tumor. There is a World Health Organization, what's called fascicle, which tells pathologists how to grade these, and the prognosis is clearly linked to the grade. And again, these are different pathology staging and grading systems, and this is a limited list. So you need to find yourself an expert pathologist and people who are used to looking at these, because I get a lot of questions, particularly for new patients, is what does this pathology mean? And it's not as straightforward as you might hope. Low grade, intermediate, and high grade. There's usually 3 grades. Low grade's got the best prognosis. High grade's got the worst. Grade 2 is in between. They're usually classified as high grade, although they don't always behave nearly as badly. And these are the curves. So what you see, these are graphs in terms of survivals. So the bottom axis is going to be months or years, and the other one tells you what percentage of people are still alive. And if you look at the curve, the top curves are all the low-grade tumors. And you can see low-grade tumors, many of these patients with treatment are going to be living 10 years, 20 and beyond. High-grade tumors is a much more serious diagnosis. And you can see how far those curves are apart. That tells you it's crucial to get an expert opinion in terms of pathology. We can also look at these tumors with genetics. There's a whole host of prognostic features that we can count on for appendiceal tumors. But I think there's a lot more interest in genetics and genomics. It's the first study I put out, which we really looked at this. On the left hand, those screens with little pink and blue bars, that's something called a dendrogram, which can be the word of the day. And even looking at this, we can look at the genetics and we can learn several things, even from the initial study, which came out over a decade ago. Appendiceal cancer is not the same as colon cancer on a molecular basis. It's a different disease. We can look at the types of mutations that are in there. You'll hear about KRAS and GNAS. Those are the 2 most frequently genes which are mutated in there. And the genetics, again, this was the second study put out, same thing. Colon cancer is distinct from appendix cancer on a genetic basis. NGS stands for next generation sequencing, and this is looking at the genetics of the tumors. And it's a busy slide, but what it shows, again, the KRAS and GNAS are the most common mutations. The mutation profiles are much different than colorectal cancer. And this is in a series of 779 patients, or excuse me, 700 patients which had appendiceal cancer. Similar one with 224 more. That's almost 1,000 patients for this rare disease that we've studied. And what it shows is the same sort of thing. It also shows us that a lot of the genetic markers we use to determine who might be a good candidate for immunotherapies tend to be absent in these tumors. So what you see at the bottom is something that came from one of my patients who had next generation sequencing. And the next generation sequencing is looking for a genetic soft spot or a target that a medical oncologist can use to deliver drugs to some of the weak genetic links in the tumor. And what you see under actionability is none and none. And that's the most common outcome when the next generation sequencing is sent. That doesn't mean you shouldn't send it. That doesn't mean it's not worth checking. But unfortunately, the yields are low, much lower than we find for a number of other things. There's a fair amount of excitement about the potential for some of these genetic targets. There are some new drugs which will can be targeted to KRAS or GNAS are coming up. GNAS is the experimental project, which is actually moving forward in Norway. You have to be a Norwegian to get into that trial. Dr. Flatmark is the one who's leading it, sort of an interesting study. That's ongoing. So that's where we're going in terms of genetics. So just to summarize it, appendix cancer is not the same as colon cancer. Extrapolating to systemic therapy from colon cancer to appendix cancer, which is what is commonly done, is unfounded on a molecular basis, although it's commonly done. We're looking for molecular targets, and genomics rarely identify patients who are better candidates for systemic therapy so far. Hopefully that'll change. We'll hear more about that later in the day. So what do you do when you find someone who has got this? What are your options when you have appendiceal cancer? If it's spread, you got several choices. Systemic chemotherapy is always an option. Systemic immunotherapy, not as useful yet, but those are choices. There's targeted therapy to some of these genetic targets. Radiation therapy is not particularly useful for this disease. I don't know anybody who recommends it other than some very rare indications. Surgery is still the mainstay of treatment. There's conventional surgery, which is open up and take out if something's obstructed. That's not usually done. Cytoreductive surgery is an operation sort of akin to what the military describe as a search and destroy mission. We're going to take your patients to surgery and take out anything that looks anything like tumor while we're there. And sometimes we'll add intraperitoneal treatment to that, either the HIPEC treatment or intraperitoneal treatment to the cytoreductive surgery. So cytoreductive surgery and HIPEC usually comes as a package. And for patients who don't have any of these other choices or are not interested in them, hospice is really your other choice for palliative care. Chemotherapy, and this is a study I did with the MD Anderson group some years ago. And you'll hear more about this coming up. Systemic therapy, particularly for high-grade tumors, is helpful. Systemic therapy prolonged PFS is progression-free survival and overall survival. The systemic therapy is not really curative, but can be very helpful here, particularly for high-grade cancers. Its use in low-grade cancers is relatively limited. And usually what I tell most medical oncologists is if you're going to treat patients with pseudomyxoma that you can't resect, treat with the goal of stable disease, because the chemotherapy will never, ever get rid of the mucin. It can help control the cells producing the mucin, but it won't get rid of the mucin that's already in the abdomen. So what is this CRS? CRS is cytoreductive surgery and HIPEC. The goal is you have a peritoneal disease, and these appendiceal tumors tend to spread overwhelmingly in the peritoneum. Only a few percent of patients will have tumors spread outside the abdomen, and then it's usually to the lung. So which is why we'll check some scans up there. So we deliver peritoneal therapy in terms of getting people to surgery, take out everything that looks or feels anything like tumor, get the minimal residual disease, deliver intraperitoneal therapy. And there's some significant advantages to delivering the chemotherapy into the peritoneum. The advantage we have over giving this into the peritoneum rather than IV is that you can literally pour the chemotherapy right on the tumor. And if you look on the right column there, there's something called a plasma peritoneal barrier. Something people might have heard of a blood-brain barrier. That tells you if you put something into the abdomen, how often does it get into the circulation? And the drugs we most commonly use for appendiceal tumor are in red. M is mitomycin C. The other one's oxaliplatinum. And the pharmacokinetic advantages versus IV delivery is 25 to 75 to 1, which is pretty significant. How do you choose patients who need to go to surgery? You have to have a correct diagnosis. It should be straightforward. You have to have they want to be able to resect the primary and the metastases. You don't want to have tumor outside the abdomen. And you have to be fit for a major operation in terms of cardiac status, pulmonary status, nutritional evaluation, performance, or what kind of shape you're in, emotional, and the support status of people who can be helping you through these experiences, because these can be quite challenging. Getting people ready for these surgery, want to see FC anesthesia, everybody goes with a bowel prep, everybody gets IV antibiotics, DVT prophylaxis, a lot of other support if you need it. And at the bottom this year, I've added caregiver support preparation. I don't think we can emphasize that enough. You need a support team to optimize your chance of getting through the experience. The goal of the surgery is complete cytoreduction to get everything out, if at all feasible, and then to deliver the chemotherapy in a uniform fashion throughout the peritoneal cavity. And finally, after you get that done, definitive closure at the end of the operation and moving to the postoperative period. How do we know how much disease is there? We usually look at something called a PCI, Peritoneal Cancer Index. This is described by a fellow named Sugarbaker 40 years ago. And basically it breaks the abdomen into 13 zones. And don't worry, there'll be no quiz in terms of how to do this unless you're a surgeon. Break the abdomen into 13 zones, and each one is graded for how much disease is present. No tumor there, up to 5 millimeters. A 2 is up to 5 centimeters, and a 3 is more than 5 centimeters. And you score each one, so the scores range from 0 to 39. And that'll tell you how much disease is present in the abdomen. After that, we want to know how completely did you get it all out. There's a classification system. There's 2 systems commonly used. There's CC system, which is more commonly used, which is completeness of cytoreduction. On the R side, the other one is residual disease score. These are both, frankly, they overlap quite a bit. That comes out of the Joint Commission on Cancer Staging Manual. That's what we use here at Wake Forest. Other places use the CC or both. And using those 2, you can tell how successful the operation is. And what you see here on the right side of the screen is an appendix. The material coming out of it, all over on the right side, that is the mucin, which is ruptured. And that's what these things look like. And this is our experience over 1,000 patients over 30 years, what we've been able to do here. And I put our data up there at Wake Forest, not because it's unique, because it's not, but just to give you an idea of what the data looks like. This is what people look like. So the top score, R0, R1, or CC0 scores, the top line on the graph on the left, those are the patients who do the best. If you have a little bit left, R2A, that's the yellow line in between. The bottom line is if you can't do a whole lot better than that and you have gross disease left over. On the right side of the screen is a graph that tells you if the lymph nodes are positive, the prognosis is worse than if they're not. This looks at what kind of shape you're in. And basically performance status means where low score wins. The better shape you are, the more likely you are to come through it. So if you don't have any symptoms or minimal symptoms, most of those patients are going to live 5 years. By the time you have extensive symptoms from this disease, you're going to be way behind the 8 ball in terms of making it over the long haul. So the fewer the symptoms, the better you're going to do. This is our experience over 1,000 cases broken into 200 at a time. The lowest curve here is our first 200 cases. So you want to go to an experienced center because it takes a long time to master these techniques in terms of how to get the disease out and how to choose the patients who should and should not be going for this sort of procedure. So to put this all together, what we're looking for appendiceal cancer is what's the histologic grade? If you're going to take patients to surgery, what is the PCI score, resection score? How much was there at the beginning and how successfully did you get it out? And these are some of your basic experience. Those are your prognostic features you can pretty much rely on. And I'm not going to talk about this. There's only been 2 prospective randomized trials that I know of, one of which I did here, comparing mitomycin to oxaliplatinum. Simple schema here. Everybody had a HIPEC. Some people, half of them got mitomycin, half got oxaliplatinum. And I'm just going to skip to the bottom line here. And I just updated this data here. This is 10-year survival data, not Kaplan-Meier projections, but this is actuarial survival. No difference if you use mitomycin or oxaliplatinum in a perfusate, which I think is important. And that's going to tell you there's a couple of possibilities here. We did quality of life. Quality of life is slightly better for 6 months with oxaliplatinum, but that actually washes out after the first year. And that's what we found here. So what did we learn from a randomized trial? Number one, randomized trials are possible. There's differences in white count toxicity, more than mitomycin and oxaliplatinum. Quality of life is slightly better for the first 6 months with oxaliplatinum. There's recently been an Icarus trial from Memorial Sloan Kettering, which compared high cytoreductive surgery with HIPEC versus EPIC, which is intraperitoneal therapy not delivered at an elevated temperature over several days after surgery. Very similar findings. That study has not yet been published that I know of, other than an abstract form. Should be probably overdue to come out, I would think. But they reached the same data, and those are the only 2 studies available for this. And what does this tell us? That oxaliplatinum, mitomycin, frankly, and EPIC now, I think we can say, have similar efficacy or lack thereof in HIPEC for appendiceal tumors. So that's sort of the introduction to the basics. We've looked at caregivers and how people do. I'm going to skip over that. And then before the sun sets on this part of the talk, I want to say that if you talk to our center or any of the leading centers that do this, treatment with HIPEC, this is a team. In order to deliver the best we can, this isn't just a surgeon with an attitude, although I will still say that's important. This is a whole team. Surgeons, anesthesiologists, supportive care people, nutritionists, social workers, on and on. And you have to work as a team to get the best outcomes for the patients. And I want to thank everybody who's tuned in so far. And at this point, I think we can probably transition and start moving towards the next phase of the morning, which is a tumor board session. I've been privileged to run tumor boards here for a long time. Frankly, it's the best part of the week. And I'm hoping we can now transition to some of the tumor board slides, if we could. Now, the tumor board is a collection of experts from different disciplines, but that all come to bear on the very tumor that the patient has. So on our tumor board today, we've got myself, Dr. Lambert from the University of Utah, Dr. Taraga from Yale, Dr. J.P. Shen, medical oncologist from the MD Anderson Cancer Center, Dr. Pai, who is a radiologist from the University of Pittsburgh, Dr. Olpen, another radiologist from the University of Utah, and Dr. Folter, who is a pathologist also from the University of Utah. So we'll be putting out some of these cases. I think Dr. Lambert has got some cases. We usually, the way these work, there's a presentation and then open discussion.
Yeah, great. Thank you. Thanks, Ed, for the introduction and for leading us off and getting us started. Again, I just want to add my comments to his about how we've enjoyed participating in the ACPMP Symposium for many years now, and supporting their mission and trying to bring people together and create a sense of community around this often challenging and disease that's just hard to understand. It's rare, it's complicated. And so again, just to provide a sense of support to everybody, that you are not alone, even though it is rare, and that there's a whole team of people here to try to help you to get the answers that you need and to get the care that you need. So I just want to make one small correction, Ed, sorry. So Dr. Pai is actually a pathologist as well. So we have 2 pathologists and a radiologist, 3 surgeons and 1 medical oncologist. So without further ado, I'm going to start with the first case. And this is a now 38-year-old woman who initially presented to medical attention due to severe abdominal pain after intercourse. So at that time, she underwent an ultrasound that revealed an 18-centimeter complex cystic mass, presumably arising from the ovary. She was referred initially to a GYN oncologist. She had some tumor markers that were done. CA 125 was 57 and a CEA was 54.5. She also had a colonoscopy and that was normal. So I actually want to stop here because this is a situation that we see a lot. I think the next step is she was taken to the operating room for a gynecologic surgery. But I just want to sort of pull the group here. When you're presented with this constellation of symptoms and imaging finding and then the tumor markers, what are your thoughts, you guys? How do you proceed, Dr. Levine, Dr. Chiraga? Because I think we're the ones that'll kind of see this first or after they've had a surgery of some kind. What are your thoughts?
All right, well, I mean, I'll take the first swing at this. And usually when I have someone coming in, I will tell you that dyspareunia is not a common presenting symptom. But frequently patients with cancer of the appendix will come in with a wide variety of symptoms. When you find this, when you have a scan and elevated tumor markers, you have to start thinking about what is the diagnosis. Clearly, we're going to need a biopsy, which is going to have to prove what this is. And I will, again, expert pathologic opinion. I know I've said this 12 times already. In my view, I don't think you can possibly overestimate how important it is to get the diagnosis correct. And then you have to start evaluating the patient in terms of, have we identified the tumor? If it's coming from the appendix, has it spread to other places? Is the tumor resectable? Can we get the metastases out? And is the patient in good enough shape to undergo a major operative intervention? And for that, you're going to need some additional evaluations.
Mm-hmm. Great.
I think,
Dr. Char?
yeah, no, I think this is, a common problem actually, that I think even for the patients on this call, many of you would be treated initially by a non-surgical oncologist and sometimes a gynecological oncologist. And I think, one of the big things that, I emphasize and I think is important for all of us is, many times we don't see the patients when they have these symptoms. I think in this patient, she has sort of atypical symptoms like Dr. Levine mentioned, but she does have an elevated CEA, which again makes us a little bit concerned that this is not just a gyn tumor. And so I think regardless of who does the surgery, the big thing is that, they need to know that appendix cancer or appendix neoplasms are a unique entity and that, this is something that if they're uncomfortable or they find something that is unusual, or let's say a surgeon is operating for appendicitis or they're operating for a gyn thinking it's an ovary, but they see a big appendix mass, that they need to be able to connect with someone that can actually help them through the decision making for this. And I think in our networks and in our hospitals, it's easier because they know who we are, and so they can always call and say, hey, I'm in the OR and I see this, and now what should I do? Or should I take this person to the operating room or not? But I think the big challenge we face is that many times there's surgeons, gynecologists who are operating on these tumors, and sometimes I think unnecessary or excessive surgery could be done. And so I think the big part is, making sure that at least they have access to a surgical oncologist, someone who kind of knows about appendix tumors and can guide, this operation.
Dr. Olpen, do you have those original scans by any chance?
I do, yes. Good morning. I want to apologize off the bat. I wanted to show directly from PACS. Realized during the opening presentation that I could not de-identify, so I've hurriedly made some slides on a PowerPoint presentation.
Oh my goodness.
And I do apologize because I thought I had the ability to do that, but let me show you the first study here. This is what we have initially when the patient presented. This is from July of 2022. The patient underwent an ultrasound as their first imaging modality, and this was from an outside institution. As we see here, there is this very, very large, just for frame of reference, we're using a transabdominal probe. This is the anterior abdominal wall right here, and we see a very large, mostly black lesion here within the front of the abdomen. It's lower abdomen, really, in the pelvis. Very complex looking mass with internal septations. There are soft tissue elements within it as well. That is kind of this uniform heterogeneous gray. They also noted that there was a similar mass arising from the right ovary that I will show on the subsequent MR. eye that was performed. The patient, this dates the ultrasound initially from July of 2022. This was performed a month later. This is an MRI. This is in what's called the coronal plane, as if you were looking at the patient from the front. And we see, just for frame of reference here, the pelvis is right here. These are kind of the hips right here that we see. A very, very large mass measuring up to about 15 centimeters in the midline of the pelvis, immediately above the urinary bladder. On these T2 weighted images, fluid is bright. And so this is kind of a complex fluid with a lot of internal septations. If you were to see this initially, you would be thinking, since this is a female, that this could definitely represent an ovarian primary. The patient also, this is another projection, an axial, meaning that we're slicing a patient. Well, axial plane is as if it's different from the coronal plane. It's just kind of a transverse section through the patient. And as you can see, again, we see the anterior abdominal wall here, very large, mostly fluid signal lesion in here with complex internal septations. This is the patient's uterus. And then over on the right side, where the right ovary should be, another similar mass that is predominantly fluid signal intensity. A little bit of something right here, I think probably represents a dilated fallopian tube as well with the patient. So I think that the presumption of all of this was that this is probably a gynecologic process rather than an appendiceal process. Dr. Lambert, did you want me to go through the entire case, or did you want to comment at this point?
No, I'll pick it up from here, and but
Okay.
thank you. I hadn't even thought about the PAX issue myself, so
I've de-identified on the
picked
fly.
up on. Okay, well, thank you for doing that. So I want to just kind of come back to the comment about. I agree. I just really want to emphasize when you're seeing something that isn't quite adding up, again, because appendix tumors are rare and unique and have a very specialized way of being treated. I think if there's anything that's kind of a red flag, so the elevated CEA for me is a sign that this may not be a GYN malignancy. Like there's a higher likelihood that this is not a GYN malignancy. And I know the gynecologic oncologists are sort of loath to do percutaneous biopsies. They're concerned about spreading tumor through the abdominal cavity, and that's really a major thing that they push back against. But in the setting, I think, where we're trying to differentiate whether this truly is a GYN malignancy versus a non-GYN malignancy, I think it makes sense to, and I would recommend that a biopsy be done before the person is taken to the operating room. However, that was not done, and she was taken to the operating room. She underwent a robotic hysterectomy, bilateral salpingo-oophorectomy, and some cytoreduction, and there was a comment made in the operative note that the appendix did appear abnormal. So I actually want to stop and pause there again too. So Dr. Taraga, you kind of commented on that. If a gynecologic surgeon or a general surgeon gets in and notices that the appendix is abnormal, would you recommend proceeding? How much surgery would you recommend proceeding with, and what do you teach your residents and other people about how to proceed in that moment?
Yeah, no, I think that's a great question. And I think the first thing is, of course, why they're there. I think there are some situations where patients have appendicitis or they're sick or they're unwell. And I think in those scenarios, at least they should do the bare minimum to make sure that the patient is getting better from that problem. So if it's appendicitis and they can take the appendix out, or if there's an abscess, draining it. So I think in those situations, do what is the right thing for the patient. But outside of that, if you're operating in this type of scenario where it's kind of elective, the patient has had symptoms and you're operating for this, my recommendation is if you go inside, I request them to take pictures of the entire peritoneal cavity. So when they're looking inside, when you do a robotic case, you're normally looking down towards the uterus, but actually looking upwards and looking at the entire bowel, the intestines, the omentum, which is the fat curtain in the belly, and the lining tissue. So that's the first thing that I recommend. And the second thing is if you're not sure what this is, and this is sort of beyond the wheelhouse, this is a large mass, the appendix is abnormal, there's ovary masses, I think the best is to just get a diagnosis if you can. So like if there's mucus around or something else, taking a sample of that. But then, my preference generally, and what I tell most of my residents, is to actually stop at that point and then have them come see one of us so that we can do the definitive operation. Because what we do know is that when patients get multiple operations, their outcomes are worse. The nature of surgery has to be more aggressive sometimes. And many times you can get away with a smaller surgery if you're doing it properly and right at the first time. So I think that's it. But I think it's a lot of education, as we all know. And I think the thing that I've learned is not slapping people on their hands too much yet, but
Mhm.
educating them constantly that this is a rare problem, but an important problem that has, important consequences when you just do something. Because often I think doctors are trying to do the right thing. They think they want to help the patient and they're doing it. But what they don't realize is that there's a consequence to that.
Great. So, sorry, the final pathology from that surgery was read as acellular mucin. She then underwent a CT scan of the chest. And Dr. Open, do you have those images that shows the
I have the
mucin?
follow-up of the abdomen that was
Okay.
performed on 10/22.
Yes, perfect. Yes.
Can I show that?
Yeah, that'd be great.
So this is just a representative slice through the upper abdomen,
Mhm.
and the uterus is gone, the ovaries are gone, and it was a relatively normal looking study, except for some very subtle findings in the upper abdomen. And it's very hard to appreciate here, but I think you can appreciate that this is all the liver in the right upper quadrant. And if you look very carefully around the periphery of the liver, we see some kind of soft tissue attenuation that should not be there. Very, very subtle. In other words, just this kind of outlining, we would say that there's perihepatic deposit right here. Also very, very subtle as well. This large solid organ within the left upper quadrant is the spleen. And you can also see some very, very subtle stranding here along the posterior margin. So this was very concerning for residual or recurrent disease that has kind of settled on these solid organs within the upper abdomen.
Thank you. That's actually a wonderful depiction of what the mucin looks like at a relatively early stage up and around the liver and the spleen. And those are the places I know that I look first because it's often the easiest to see, but it can be very, very subtle. So that was very helpful. Thank you. So she was referred to me, and we did a HIPEC in December of 2022. She had a complete cytoreduction and took out her appendix at that time. And Dr. Athelter, I was just wondering if you could review the pathology that we found there.
Yeah, and so I had a couple thoughts while you guys were talking as well. So intraoperatively at that very first surgery, had they sent a frozen section, meaning an intraoperative consultation of the ovary, in the pathology world, we've learned that if we see a highly mucinous tumor with maybe some strips of epithelium, even if it seems like the predominant organ is the ovary that's being involved, we try to direct them to at least go evaluate the appendix, if not resect the appendix, so we can be sure where the primary lesion is. Because there's other cancers that can cause a similar initial appearance. And so from our perspective, we like to know the site of origin, so the appendix. And if they send that during the surgery, you're still having a gynecologic surgery. You're not going to back out at that point, but at least we can make a diagnosis of the primary site of disease. We've also had to teach our gynecologic pathologists that if they see, again, a highly mucinous tumor with some strips of epithelium, to please come consult their GI pathologist colleagues, as the nomenclature has been confusing over the years. So we've kind of had a widespread education amongst ourselves as well regarding this disease process. So the first surgery, can you see my screen?
Yes, something's happening. Yeah, there it is. Yeah.
Right, okay. The first surgery that came out when we didn't know where the primary site of disease was, revealed really large mucin pools. So that's what all of this gray material is that you see here kind of dissecting through the pink collagen. This is that mucin. And there's a lot of it. And most of it does not have any cells in it. It's just mucin. And it's surrounded and dissecting through all of this fibrous tissue. And then occasionally you get a strip. Oh, that's not on the screen. Of this very low grade epithelium. This is a nucleus of the cell, and you can see that it is all basally arranged, polarized outward here. And then the apex of each cell, I'm kind of following along each cell, is kind of stuffed full of mucin, if you will. And so we are looking at both cytology, referring to the appearance of the cells, and the architecture, meaning the arrangement of the cells in general, is all very low grade in this particular specimen. This is, again, the first one that came out. And so this one was called a low grade mucinous carcinoma peritonei. Actually, it was signed out descriptively because we didn't have the primaries. It signed out as involved by low grade mucinous neoplasm, with a comment that said might be from the appendix, essentially. And then Dr. Lambert took the patient back to the OR, and they resected the appendix. And we found, you know what, humor me for a second. I pulled up, and I think I de-identified. I had the same worry as Dr. Olpin this morning, but I think I did it. Humor me by looking at a normal appendix very quickly. So here is a cross section. This is the tip that's bisected. And here is a cross section of a normal appendix, where you can appreciate this is the epithelium. This is called lamina propria, which is full of inflammatory cells, kind of white blood cells. Again, this is all normal. As you go out through the layers of the wall of the appendix, you have something called the muscularis mucosae. It's a smooth muscle layer. Submucosa that has collagen and fat. A bigger smooth muscle layer called the muscularis propria. And then out here is the serosa, or it's the mesothelial lining. So like when a surgeon goes in, they're looking from the outside. So this is the surface they see out here. We are concerned with this epithelium. This is what's going to go bad, if you will, in a appendiceal mucinous neoplasm. Okay, so now we're looking at this slide. It's a little dirty. And you can appreciate that this epithelium looks different than the nice low-grade epithelium or the benign epithelium of the two other cases or slides that we just looked at. These nuclei, these purple things, are a lot more jumbled up. Their architecture is more complex. They're kind of tufting, or what we would call micropapillary structures. So again, from a cytologic and an architectural standpoint, this is much more complex. So this neoplasm, we ended up calling a Hammond, a high-grade appendiceal mucinous neoplasm. And then the additional samples of the mucin in the peritoneal cavity, we actually kept a little bit descriptive, because you usually suspect that the mucin out in the peritoneum will be concordant from a grade perspective with the appendix. And this one was a little hard because some of it was still really very low grade, being hypocellular, not many cells, and the epithelium was relatively bland. And then occasionally we found some cytology that you could argue was a little higher grade. And so we just ended up describing it as mucinous carcinoma peritonei, kind of with a range of grade 1 to grade 2.
Great, thank you. And I just want to sort of emphasize for the people who are participating in the symposium that, not all, it's not one size fits all for pathologists. And Dr. Pai and Dr. Affelter are pathologists who work in an academic medical center who have dedicated their life to not just reading pathology slides to provide a diagnosis, but to better understand the disease. The diseases that they are focusing on, and they're subspecialized within pathology. So as Dr. Appleter mentioned, there are pathologists who focus particularly on gynecologic malignancies. There are pathologists like Dr. Pai and Dr. Affelter who focus specifically on gastrointestinal malignancies. There are pathologists who focused on breast, on lung, you name it. They're subspecialists within pathology, and we're so grateful for them, especially in this disease, that they have an interest in it, because it is complicated. And even though it's rare, it comes in a wide variety and a spectrum, and it's very complicated, and the nomenclature is constantly changing. So it makes it hard not only for patients and their loved ones to follow what's going on, but it makes it hard for us to follow what's going on as well sometimes. So Dr. Pai, anything else to add? Sorry about Hammond versus Lemon.
Yeah, I entirely agree with Dr. Affolter's diagnoses. Hammond is really rare at UPMC, University of Pittsburgh. In our files, we only have about 15 cases total over a 20-year period of high-grade appendiceal mucinous neoplasm. So it's a really rare diagnosis, but the case certainly looks like that. And discordances are actually kind of rare too. You get, some cases where the primary looks like high grade, like this case, but the peritoneal disease looks mostly low grade, which seems to be the case in this case. And that happens about 5% in our experience here at Pittsburgh. So this case is rare in that there is discordance between the primary tumor grade and seems to be somewhat of a discordance between the peritoneal grade, which has predominantly low grade. Is that what your thought was, Dr. Affolter?
Yeah, I think that's why we were hesitant to just call it Hammond and then low grade peritoneal disease, which is why we were a little hedgy and kind of described it in our comments. It's interesting, sometimes being a referral center, you get cases after they've, you see the biology of it and you can kind of watch it change over time. And that kind of can contribute to, what the data shows. And if it's a rare diagnosis, we stay a little more descriptive sometimes.
And I think, again, this particular scenario just echoes that, where it's, we love it when the pathologist can tell us this is exactly what it is, like 100%, it's clear, it's black and white or purple and pink or whatever, and it's just clear cut, this is what it is. But a lot of times with this particular disease, that's just not the case. And we know you guys do your best to try to help and understand what's going on and help us so that we can make the best recommendations for the patient. So on that note, so Hammond, so we have this Hammond, we have mostly low grade peritoneal disease, some areas of high grade mucinous neoplasm in the peritoneum. Dr. Shen, would you recommend any, if this patient was referred to you, what would be your thoughts about treatment at this point?
Great. Yeah. So this is a great case because it highlights the complexity, and it would be easier if the tumors were kind of uniform across one patient, but it happens actually quite frequently that in the many different organs or the different metastatic sites, the morphologic appearance is different. In our experience, when you see this kind of discordance, the outcome seems to be driven more by the peritoneal disease. And so with low grade peritoneal spread, and it's complete cytoreduction, so no evidence of tumor remaining, we would not recommend systemic therapy. As Dr. Levine mentioned at the beginning, we're working on better systemic therapies for appendiceal cancer, but for the most part, we're limited to drugs that have been shown to be effective in colon cancer. But a low-grade appendiceal tumor is really nothing like colon cancer. And we actually did a prospective study showing that the traditional 5-FU-based chemotherapy for colon cancer really doesn't do anything for purely low-grade tumors. So, the Hammond component in the primary is concerning, so we'd want to kind of watch the patient carefully. But, you can definitely cause harm with systemic therapy, and there's really no data that suggests that it's going to help a patient like this. So we wouldn't offer chemotherapy to this patient.
So we're gonna kind of get up to the most recent aspect now. So she did very well for a couple of years and has been under surveillance. We routinely do every 6 months with the CT scan and tumor markers for the first 2 years, and then yearly after that. So she's now on a yearly annual surveillance schedule. So Dr. Olpen, can you present her most recent scan? Oh, Dr. Olpen, you're muted. We can see your scan, but we're not hearing you.
Sorry, can you hear me now?
Yes, we can hear you now.
Sorry.
Thanks.
I just wanted to illustrate the fact that this study was performed 2 weeks ago, in late September. I wanted to talk very briefly about the fact that contrast is our best friend as radiologists. How absolutely important it is that we use good technique. We have both intravenous contrast. We see the iliac arteries right here that are very bright with contrast material. Also, even more importantly in my mind is that we use oral contrast in these patients. These are the patient's small bowel loops here, and then we see a little bit of the cecum and ascending colon here within the periphery of the abdomen as well. And our goal is to opacify these loops and turn them white so that we can look for subtle metastatic deposits. And thanks for entertaining my little diversion here.
Oh, that's very helpful because we get that question asked a lot from patients, like, do I need contrast? So this is a great illustration of why we insist on both oral and IV contrast. So thank you.
Well, the oral contrast is not particularly, a lot of patients don't want to do it, but we really insist on it if they possibly can. They'll drink it maybe 60 minutes before. Hopefully it will pass through the stomach into the small bowel and make its way to the colon before we perform the study. And in this case, it did, and it was very helpful. What was new that we did not see on the prior images were some very subtle nodules here in the right lower quadrant. This again is the small bowel, and it's coming into the ascending colon or cecum right here. We don't actually see that transition ileocecal valve right there, but what we do see are some subtle nodules right there that were not on the prior images that were suspicious for disease recurrence. There's an even larger area here. This is lower down in the pelvis. This is all urinary bladder. This is the patient's hips right here for frame of reference. This is the patient's rectum. The uterus is gone, and this is just a little bit of a loop of bowel that we're just barely kind of seeing in this image. But what was very concerning to us, again, the beauty of this is that the bowel is a very different shade of gray. This is nearly white, but we see this darker area right here that was along the top of the vagina, or what we would term the vaginal cuff, that did not belong there, and that was new. And again, that was also very concerning for disease recurrence within the pelvic floor as well.
Great, thank you. So tumor board panel, what would you recommend now at this point? This is 3 years out. CEA is slightly elevated at 3.1. The remaining tumor markers are normal, and we have this low volume, what looks like a low volume peritoneal recurrence of Hammond/Lamon.
All right, I'll take a shot. So I think what you're seeing is recurrence, and when we see recurrences, which we never want to see, you ask yourself several questions. How long did it take the tumor to recur? The longer it takes for the tumor to recur and for the radiologist to be able to find it, the better the outcomes tend to be, because that speaks to a relatively slowly progressive process. So I'm glad it's more than, if you have to have a recurrence, the later it is, 3 years out is already getting to be a fair length of time. So at this point, you're looking at a couple of choices. So choice number one, you could just watch and wait, see what happens, watch it for put a short interval follow-up, come back in 3 or 4 months, repeat the tumor markers, which are barely elevated. You've got these small things which are not all that large, but clearly worrisome. If they're getting bigger, you'll know for sure then. The other choice would be to think about going back to surgery. And you could potentially start with a laparoscopic exploration, but getting down to see that tumor in the pelvis with a laparoscope is going to be, in my hands, pretty challenging. Also, the spots in the back behind the appendix, those aren't going to be immediately visible without a fair amount of dissection either. So you've got a couple of choices. To me, would be short interval follow-up versus tell the patient that they've got recurrent disease, take them back for a repeat procedure.
Dr. Taraga, Dr. Shen, any other thoughts?
I mean, I think one of the challenges, I guess, maybe perhaps a little bit of a disservice and a plug to Dr. Pai and Dr. Affolter, is, when we call these high-grade lesions, it creates this sort of sense of panic and worry that, are we dealing with something that is, very aggressive. And I think in my mind, I think of high-grade appendiceal mucinous neoplasms between the spectrum of the low-grade neoplasm, which is obviously very slow growing, and then even the well-differentiated adenocarcinoma. So it's not quite a cancer, even though it has this high-grade term in its title. And so I would agree with Dr. Levine. I think it's a 3-year interval. It's in a difficult spot. It's the first time we're seeing it. And, my general sense would be to watch it for a little bit longer to get a sense of whether this is a fast growing recurrence, this is going to be slow growing, and it kind of stays at that place. And if CEA is a good marker for the patient, I think that's a reasonable thing. Now, if the pace picks up, so let's say the patient starts growing really fast or she becomes symptomatic, then I do get worried that maybe, could it have been a sampling error? Like one of the big issues when we take mucin out from the peritoneum is there's a lot of mucin, and, the pathologist can only process so much information out of that mucin. And so could we have missed something in the diagnosis of this? And so in those scenarios, then going back becomes an option. I think I agree with Dr. Levine. I try laparoscopies a fair amount, but, looking down in that pelvic cul-de-sac after a peritonectomy from before would be quite a nightmare.
So one question: did this patient get HIPEC with the first?
She did.
Yeah. So it'd probably be very difficult to do another laparoscopy because of the scar tissue. You exactly echo Dr. Taraga's point. If it's possible to get another, update the pathologic diagnosis, I think that's very important, just because, it is possible. Most of the time, high-grade tumors show up high-grade, but it is possible that a low-grade tumor can transform into a high-grade. This might be because of the sampling error that he mentioned. And, I think a lot of times we don't necessarily get repeat biopsies on low-grade patients when they progress. So I think I think the reported kind of rate is like 10 to 15% in the literature, but I think that might be an underestimate. So I think, given that it's probably going to be really difficult to get at these lesions, I won't speak to the morbidity of the surgery, but, given that location kind of near the rectum and the bladder, I mean, it looks like, another surgery might be very morbid. I think watching weight would be reasonable. We a lot of times send circulating tumor DNA. If that's positive, that'd be concerning that it's more high grade. Low grade is most likely going to be negative. So which not a negative result's not necessarily very helpful, but a positive result would make me very worried and maybe more inclined to want to start systemic therapy. But I think in these low grade tumors, we've had success with immune therapy, atezolizumab and bevacizumab, which would be an option. But I think watch and wait, this is asymptomatic small volume disease, so short interval scans and labs, I think, is also a great option. Great.
Thank you very much. All right, we're going to move on to the next case. So this is a now 64-year-old gentleman who initially presented to medical attention for evaluation of an elevated PSA. At that time, he had a pelvic MRI performed, which showed some ascites and some peritoneal nodules. And then he had a CT scan. Dr. Olpen, do you have those by any chance?
I do.
Great, thanks.
This was the way that this patient presented back in 2022. Again, oral contrast on board. We see bright contrast within the small bowel loops. what we should see in a normal individual is intra-abdominal fat everywhere, interdigitating between bowel loops. This attenuation right here, for example, in the retroperitoneum is example of what fat should look like. This is subcutaneous fat as well. We would hope to see fat throughout the abdomen. What we're seeing here is floridly abnormal. We are seeing soft tissue attenuation throughout. It looks like it is sandwiched between the anterior abdominal wall and all of these bowel loops. In other words, soft tissue infiltration involving most of this structure that we refer to as the omentum. The buzzword that we will use in the medical community is omental caking. Sort of turns you off cake when you hear this term, but this is one of the terms that we use, and that's a beautiful example of that. I just wanted to jump ahead. I hope I'm not getting ahead of myself here, but I just wanted to show this is a coronal plane, again, with contrast. We see bowel loops, small bowel loops, and then we see a little bit of the transverse colon right here. Very, very abnormal again, with all of this intermediate attenuation, soft tissue-y kind of a substance that surrounds all of the bowel loops, insinuates throughout the mesentery and the peritoneum, that is outlining all of the organs. We're seeing a little bit of liver here. The material kind of wraps itself around the liver. This is just a beautiful example of pseudomyxoma peritonei that we see beautifully here. I hope I'm not jumping ahead, but this is what the patient looks like 3 years later. We still have a large amount of disease that is actually decreased in extent. It's interesting that this has sort of evolved over time to be more smaller, but kind of multilobular in appearance, more compartmentalized to my eye, even though the overall burden of disease appears to have decreased between 2022 and now.
Thank you. So, Dr. Levine, Dr. Taraga, looking at the 2022 scan, I know you're only getting a couple of screenshots, and you would go through, more detail, but just your thoughts. How do you approach somebody who presents with this clinical scenario and these kind of images?
Again, the key determination is going to come from your pathologist. If this is a low-grade lesion, then I'm going to want to be very aggressive with it surgically, because as Dr. Shen said, systemic therapy is got a supportive role to play, but it's not going to be effective in taking down massive bulk disease like that. And there's palliative value, even if you can't get it all out, there's palliative value into getting that larger mental cake out of there if you can. Even though there's a lot of disease there, you can potentially remove the vast majority of this. And one of the things that I'm looking for is the distribution of the bowel. So you can see they're beautifully lit up. The white material is the contrast that the patient drank. And you can see the bowel has still got some space in between it. It doesn't look like it's all stuck or matted together. And again, if you're a patient looking at this, you're wondering how we see that, but there's specific patterns that we have in terms of how the bowel looks. There's just a little bit of space in between them. Once that's lost, we'll not be able to pick it out. And one of the things that makes these operations feasible is that there tends to be relative sparing of the bowel till relatively late in the course. If all the small bowel is involved, you can't really take it all out because that leaves the patient with something called a short gut syndrome, which means you're basically on IV nutrition for the rest of your days, unless you get a small bowel transplant, which are extremely hard to come by. I don't know anybody who does that for this indication. So I think, to me, if it's someone who is going to be a candidate for a procedure, first thing is, what grade is it? We want to make sure we don't have disease outside the abdominal cavity. The radiologist certainly would have told us that if it was there. So I'd be looking to see if we can prepare this man for an operation if he's got low-grade disease.
Great. Dr. Taraga, anything?
No, I think Dr. Levine summarized it really well. I think pathology is super important. And I think, for the patients that are listening in, I think the point Dr. Levine was making about the intestines is, a critical one. There are a few things that make us as doctors a little bit worried, or surgeons worried about, when we see a lot of mucin or PMP1, things like multiple bowel obstructions. So if the patient's intestines are twisted and not letting food go through, or if the kidney tubes start getting blocked, called ureteric obstructions, or if the fluid inside the belly starts looking more like just thin fluid and not just like thick mucus-like fluid, which this looks like a bagomental cake and some mucin. But if it's full of like very thin fluid, we get worried. Or if there's very extensive infiltration by the liver. So there are certain things that we all look for very closely. And of course, we want to make sure that most, and in fact, almost all of the disease is in the abdomen, and that we're not seeing enlarged lymph nodes or other types of things in the rest of the body. So I think pathology is most important, and then, careful study of the scan with the radiologist, I think is critical.
Thank you. Dr. Affolter, he did have a biopsy. I don't know if you have that path.
I do. Let me share my screen. So this is an omental biopsy. It's a core needle biopsy. So you'll see kind of strips of tissue that essentially represent what came out of the bore of the needle. Similar to the last case, you'll see dissecting pools of mucin. So this is the mucin. Again, it kind of has this wispy appearance, gray. If we only see this, we sign it out as organizing acellular mucin, because that has a different prognosis than if there are cells in it. But as you scan around, you can find strips of, again, similar to last time, low-grade epithelium. So they're kind of hugging the edge. Again, the nuclei is down here at the base. The top has mucin in it. Also similar to last time, we don't actually know what's going on with the appendix yet. So we are a little bit descriptive in our sign out, and we also did immunostains. So in pathology, we can do additional stains that are specific to antigens or proteins on a cell that help us favor where that cell is coming from. So in the intestinal and or appendix epithelium, this is that strip of epithelium. You see how it's brown. This is called a cytokeratin 20. That helps us favor lower gastrointestinal tract, as does this immunostain, which is the CDX2. You can see this is a nuclear stain, whereas the other one was a cytoplasmic stain. It's nice to have both, just for kind of a variety, to protect yourself from some sort of weird artifact that might happen. And so we signed that out as low-grade neoplastic epithelium in a background of dissecting mucin, favor mucinous carcinoma peritonei, low-grade.
Great, thank you. So Ed and Karen, when looking at this scan, you're thinking about, okay, it's low grade. I agree, a surgery. How do you talk to people about what the magnitude of surgery that might be required to remove all of this tumor? Because one of the things that I find that I have a very hard time predicting just looking at scans is how stuck the tumor is going to be to the various organs, right? So we hope that when it's low grade like this, that we'll be able to get in and do a lot of peeling and cleaning and swiping and that kind of stuff. And we can look at the edges of the liver to see if they're scalloping, or that can give us a sense of if it's a little bit more pushing, a little bit more solid, a little bit more stuck. But unless I would love to hear if you guys have a way of knowing absolutely before surgery, but I find a lot of times that it's just, you don't know until you get there. And if you get there and you find that it's going to require removing somebody's entire colon or removing their entire stomach to get this out, what do you talk to patients about beforehand in that regard?
Dr. Lambert's an excellent question, and I think it's absolutely crucial that before we operate on someone, we have a sit down in clinic and talk about exactly what this operation is and what it isn't. It can absolutely be life-changing. So sometimes to clear all the tumor, you have to leave the patient with a colostomy. You cannot always assure they won't have that. Complication rates of these procedures, if you're honest, is at least 40%. And the average hospital stays are in a 1 to 2 week long. These are substantial operations. Now, sometimes patients have a lot less disease than this, and those those issues are not nearly as risky. For someone like this, they have to be prepared for what is potentially a life-changing operation. And I think you have to have a heart-to-heart. Now, though you don't want to lose your colon, the problem is if you don't remove the tumor, which is encasing the colon, your bowel's going to obstruct. It's not going to work in any event. You're going to wind up with an ileostomy. So you're not really a whole lot better off, and the outcomes are going to be poor. So this patient, if you left them alone, would progress to a frank bowel obstruction, I would think, within 6 to 12 months at the outside. So you're forced to undertake a draconian operative intervention. And it's very important to sit down and talk to the patient. In terms of can you really tell, I think Dr. Lambert brings up a crucial point is you cannot always tell. Sometimes you can get in there, the cemental cake will lift off. You can dissect it off the organs. You can leave most of them there. You don't have to do major bowel resections. And if you can, that's terrific, but you can't count on that. And I'd love to tell you that I have a magic radiologic sign that I can use, and I do not. And when I tell the patient, this is a search and destroy mission. You're not going to know what you're doing. If you're a football fan, you have to call an audible at the table. You have to be willing to move based on what your intraoperative findings are. And you can't always tell when you have that giant omental cake in there, getting a laparoscope under it to see what's going on. Difficult to impossible. Sometimes for someone like this, you have to be willing to just take them to surgery. And these operations are really their maximal efforts to remove tumor. To go in there and just nibble at it really doesn't achieve anything. So I think if I can highlight, I think I'm reading into your question a bit, but preparing the patients, I don't think you can possibly underestimate the importance of how important it is preparing patients for surgery of this magnitude.
Yeah, I mean, I think, this is a very difficult, question you ask, actually, Laura, because I think for, not only major cytoreductive surgery, but even major GI cancer surgeries, I think it's a very difficult, shared decision making for how much surgery to do, how to prepare for these surgeries. And I think we're all trying to figure it out together. And I think, ACPMP has actually been a great partner with some young investigators who are actually exploring this exact question of, how do you make these decisions together so that patients feel informed but not overwhelmed? Because it is very overwhelming to hear, half your organs could come out, your colon could come out, your intestine could come out, your spleen could come out, your gallbladder, your uterus, ovaries. So I think it could be a very difficult, sort of an overwhelming way of thinking. I think for me, I mean, I would echo everything that Ed said. There's a few things that, certainly must be done before surgery, which is sort of preparing for these surgeries with prehab, making sure that, patients are strong and able to tolerate these surgeries, that, they're emotionally and psychologically as best prepared as they can be. I think connecting with other patients sometimes helps some individuals kind of learn a little bit about what the effects of surgery could look like. I think for young women, especially thinking about fertility and preservation of their sexuality is important to just think about and at least discuss those options. Similarly for men, thinking about their sexual function as well. So I mean, I think there's a lot of components of this decision making that require I think a team effort. And I wish I could tell you we all do it superbly and that it's like, great even in the experienced PMP centers. But I think it's a challenging thing. And I think, future research and partnerships are going to be important for us to truly determine, how much information does everyone want or need, and it's probably individualized, and so that we're not overwhelming, but at the same time, really, capturing the magnitude of this operation.
Yeah. Great, thank you both. So, so this person went to the OR, and as you can tell, at the time of surgery, we unfortunately found that the tumor was one of those more sticky situations, and to get a complete cytoreduction was going to require removing the entire colon and the stomach, and we actually hadn't really had that conversation prior to the surgery. So I performed a palliative omentectomy and took out a fair bit of tumor, got the appendix out. And that did reveal low-grade mucinous neoplasm of the appendix. We had a discussion about going back to do another surgery, possibly to remove the remainder of the tumor, again, with the plan that it would require a gastrectomy and a colectomy. And at that time, the person decided that was not what they wanted to do. And so we've been following along. And as you guys have alluded to before in discussions, these can be very slow growing tumors. And so we've been following him along. You can see the most recent scan now. Some abdominal symptoms, maybe starting to feel the impact on bowel movements and some earlier satiety, but otherwise maintaining an excellent quality of life. He and his wife have actually been trotting the globe for the past couple of years and really enjoying a lot of vacations in a lot of different areas that I get to hear about when they come to visit me. And so that's where we are now. But one of the questions, and Dr. Levine, I'm going to direct this one to you, and you know what's coming, is there a role for Bromac in this situation? So your thoughts on that?
That's easy. The current answer to this question is no. As long as you're a candidate for surgery, Bromac is not currently part of the equation. What is Bromac? It's a combination of two drugs. The most active part of it is bromelain, which is an enzyme that breaks down the mucin. And it can break down the mucin so that you can take what is the thick mucoid-like material. And the problem for the radiologist who usually drain fluids all the time is if the fluid becomes too viscous and thick, you can't get it out through the catheters they put in. It's a little bit like trying to suck grape jelly through a straw. It's just too viscous, it won't go. You can liquefy that with the Bromac. The problem is it's only available on an experimental basis. It's from Australia. It's got a limited role for patients who have got large pools of mucin that are causing symptoms. In this country, it's only available on what they call a compassionate use basis, which is case by case, requiring FDA approval before you deliver the agent, and provided the agent can be obtained from Australia. So I would love to tell you that it was a cure-all. It is not. It's still being looked at. We're looking at it here in terms of what can it do in terms of fighting tumor, but it is, I think, has to be reviewed as of today as a mucolytic or an agent to dissolve mucin, which is palative because, again, that does not really have much, if any, effect on the tumor cells that are producing the mucin.
Right. Dr. Shen, any thoughts or clinical trials or other options for treatment for a person in this situation?
Yeah, so I think the first thing is just that a lot of medical oncologists might see this, and unfortunately, the literature, and people were kind of trained to think of appendix cancer like colon cancer, and so colon cancer chemotherapy doesn't have any role here, but options would be you could think about immune therapy. Again, this is the patient population where we saw progression-free survival benefit in atezolizumab plus bevacizumab. The advantage of that is it's pretty well tolerated. With immune therapy, about 5% or less than 5% of people will have an adverse immune reaction, but 95% of people really don't have a lot of side effects, and so that's something that could be considered. I agree with what Dr. Levine said about Bromac. I mean, I think that hopefully it will become more available. And they've had a lot of the company that produces this had a lot of issues with the production in Australia and regulatory issues. I think that potentially it could work in combination with immune therapy. We think that part of the reason that the mucin probably does a lot of things, but it probably also prevents the immune cells from really getting into and in proximity with the tumor cells, which they need to do in order to kill them. And so I think, again, this is theoretical, but we think that there's reason for potential synergy. Unfortunately, that's not a 2025 option, but hopefully in the reasonably near future. And then the other thing that potentially is coming is that most of these low-grade mucinous tumors are going to have KRAS mutation. There's not a lot of drug development going on in appendix cancer, although we're trying to spur this, but we're trying to get KRAS is commonly mutated in colon cancer, lung cancer, pancreatic cancer. And so there's many companies that have KRAS inhibitors that are in late stage clinical development. And so we're attempting to start our own clinical trial specifically in appendiceal cancer. We're just trying to find the right industry partner. So I think that's if there was an option in a pan cancer study, for a KRAS inhibitor, that would be something else to consider.
Great, thank you. All right, we still have a few minutes left, and I want to get to one more case, but since we have less time, and this is a complicated case as well, but an interesting situation from the things that we've been discussing. I'm going to go through a lot of the history, and then we'll kind of get to the most recent things that are happening now. So this is a now 55-year-old woman who presented 2 years ago in December with abdominal pain. At that time, she had a CT scan, which showed some ovarian cysts and an abnormal appendix and some pancreatitis, actually. The CEA at that time was 97. The CA-125 was 26. She was referred to a GYN oncologist who recommended surgery, and she had that done in December. At that time, she had a robotic-assisted bilateral salpingo-oophorectomy, omentectomy, cytoreduction, and appendectomy. Interestingly, over that very short period of time, her CEA went from 97 to 120, and the CA-125 remained normal. When the pathology, and this is going to be largely a pathology review, so I'm going to kind of go through the story of the pathology, and then Dr. Affolter is going to try to show us what she can, although some of the slides are missing. So upon initial review here, the final pathology was read as a low-grade mucinous neoplasm of the appendix. And then she was referred to me, and we started following her along. I was concerned that there might be a small amount of mucin present behind the liver. Her tumor markers at that time showed a CEA of 26. We did a short-term follow-up, and it went up to 35. I did a diagnostic laparoscopy in May of 2024, and there were mucinous implants, and the CEA then rose to 95. This is over very short periods of time that CEA is rising this rapidly. A colonoscopy was normal. In August of 2024, we did cytoreduction and HIPEC. And I'll have Dr. Affolter review that pathology, which was also again read as low-grade mucinous neoplasm. And then shortly there, fast forward about a year, or not even a year, like 6 months, and the CEA started rising again. It was up to 110. So we discussed the role of a redo cytoreduction and HIPEC, which was done in May 2025. So about 9 months after her original surgery. And I'm going to stop at that point because that's where we are now, essentially, and have Dr. Affolter review the pathology so we can see what the story from the pathologic side.
So as you mentioned, I don't want to get the impression that the slides are just missing. We can't find them.
No, so thank you.
Slides to MD Anderson right now, so we don't have access to them because they're being reviewed. However, I will also make note of, it was called a low-grade appendiceal mucinous neoplasm at an outside community hospital. And so to repeat the point that we've made multiple times, I guess, it is important to have the pathology seen at a facility that reviews lots of cases, because here it was a difficult case. 100% this was a challenging case, but here it was called appendiceal mucinous neoplasm, favor predominantly low grade, see comment. And then again, you get the impression when they're challenging cases, the larger the comment is, right? That's how you can tell how hard a case is. We write little novels in the pathology reports. And you go down and you read the comment, and it says that although the majority of the neoplasm does appear in line with a low-grade mucinous neoplasm, there are occasional foci, and it kind of describes it. Pleomorphic hyperchromatic nuclei, increased NC ratios, all these things are worrisome to the pathologist. And it says that a high-grade appendiceal mucinous neoplasm cannot be excluded, nor could a small focus of mucinous adenocarcinoma arising in the setting of an appendiceal mucinous neoplasm. So we're essentially saying, even though the majority of this thing looks like a lamin, we cannot exclude that there's something worse here, okay? And again, I realized from the surgeons and the clinicians' perspective, this isn't an ideal report, but we can only say what we see. And I will also make the statement that we know, and most of the community knows, that the entire appendix should be submitted, right? To Dr. Pai's earlier point, Hammonds are so rare because if you submit the entire appendix, frequently you can find an adenocarcinoma associated with them, and so that the diagnosis of Hammond doesn't really exist anymore. You've moved on to something worse, right? So anytime that you have a mucinous neoplasm, you submit the entire appendix so you can look at the spectrum of the disease that's present. All right, so that's the path I don't have, unfortunately. But then the procedure where Dr. Lambert took her back and took out additional material. Here's the pathology. And you can see, so this is the, what is this? This is left pelvic nodule, is what it was called, but there's a lot of pathology. And you can see that there's still these mucin pools, and there's higher grade epithelium. It's not, the cytology is not low grade anymore. The nuclei are a little uglier, more jumbled. And then if you go to some of these areas, you can wonder if there's desmoplasia here, meaning that the stroma around the glands are reacting to the epithelium. But there's still this kind of dissecting mucin pattern. So we ended up, and there's these floating clusters of cells as well. So the majority of the specimens that came out with this particular surgery were called mucinous carcinoma peritonei, or the synonym pseudomyxoma peritonei grade 2. And in the pathology literature, if you're calling something a pseudomyxoma peritonei grade 2 or a PMP grade 2, you are essentially saying that this could be from a high-grade appendiceal neoplasm, but it also could be like a mucinous adenocarcinoma, and this is what it looks like out in the peritoneum. Again, the nomenclature gets very confusing here, but I do think that's a good way to go about it, because frequently it's really hard to tell. I would love Dr. Pai's input on this case.
Yeah, so when you show this slide at low power, you're automatically seeing a lot of tumor epithelium. And as a pathologist looking at appendiceal pseudomyxoma, if you have a case that has a lot of epithelium, you're pretty much automatically not dealing with a low-grade tumor, because low-grade tumors are very low cellularity. So this one's, just at low power, you could tell is going to be a grade 2 pseudomyxoma. The primary tumor was kind of interesting in that I think it was mostly low grade, but had a focus that was concerning for either Hammond or adenocarcinoma. You see that, that focus probably was an adenocarcinoma, and now in the peritoneal cavity, you're seeing the representation of the adenocarcinoma that's now present in the abdomen. So yeah, these are always challenging cases. Every case is kind of got different, morphologic appearances, and even amongst our specialists, we show the cases to each other. We meet daily, basically to review the histology as pathologists of these challenging cases, because we want to make sure we're approaching it the right way and arriving at the right diagnosis.
Great. And did you show the final pathology from May?
Let me look at what I showed. Okay, so I do not. So this is where it gets tricky, and it is a nomenclature issue. Share again. So this is the final pathology. You will see that it looks very similar. But a different pathologist signed it out, and we do, Dr. Pai said, we always kind of discuss this. And at this point, it's understanding the biology of the disease, where it's recurring quickly. It is it's infiltrating organs. This is the spleen back here. It still has a lot of epithelium. It's infiltrating. We decided to bottom line this one as mucinous adenocarcinoma. It is the same process. It's not like there's something else happening here. It's just that the biology and the appearance and the pathologist that signed it out, we decided to bottom line as mucinous adenocarcinoma. And the desmoplasia was getting more striking. This is where pathology gets really tricky, and it's frustrating, and I will concede that.
I think that, to your point, Dr. Appleton, like you said early on in the first case, was, over time, it's helpful to see the biology of the disease, how it's behaving, and then, the things converge, right? So the tumor biology is telling us something, what we're seeing at surgery or on imaging, and then the pathology, they all finally come together. So I think we've been dealing with an adenocarcinoma all along. And so, Dr. Olpen, do you have like the most recent images?
I do. Would you like me to skip over the initial in the interest of time, or?
I think if you can just show what's most recent now.
Okay, so this is what they look like. Most relevant. We see again, very subtle. This is the liver. And we see this very, very subtle soft tissue wrapping again around the liver. It has that buzzword that we would use, the scalloping appearance here, the way that it sort of indents the liver along this posterior segment of the right hepatic lobe here with all of this soft tissue is very telling for residual or recurrent disease in the upper abdomen.
Thank you. Yeah, so it appears to be like the recurrence appears low volume. The most recent CEA, I think, is like 26, so it's relatively low, but still not normal. So thoughts from the board, what recommendations, next steps, what would you?
And so what was the timing for the recurrence from surgery to recurrence?
She had her, so let me pull that note back up, sorry. So she had her original surgery in December of 2023. She had first HIPEC in August of 24, second HIPEC in May of 25. So 5 months ago.
So just 5 months. Yeah. So I think, Dr. Levine said this earlier, the time to relapse is a really important feature. And I think that, there are some questions in the chat about how the tumor board operates. And so I think most major centers have a similar tumor board where you have the pathologist and the clinical history and the imaging all together, because you kind of need all three to put it together. And, with just the images or just the clinical history or just the pathology, it maybe wouldn't fit. But, everything about it's recurring faster than you'd expect for a low-grade tumor. It's got areas that are concerning that's more than low-grade on the initial. The tumor markers remain elevated. All of that is all of that suggests this is not a low-grade tumor. It's behaving like at least a grade 2 tumor. And so I think that's why it's really critical to have the multidisciplinary discussion. And so, with the relapse, only 5 months after a complete surgery, we would want to look at systemic therapy for this patient because, likely, if the disease was resected again, it's likely going to relapse again unless we can really change the disease biology with systemic therapy.
Yeah, Dr. Levine, Dr. Taraga, any other thoughts or comments?
You see this not uncommonly, and I think there's a couple of important points that to me jump out of this case. Number one is the low-grade histology does not always belie a low-grade benign experience for the patient.
Yeah.
And I've got about 5% of patients, very similar to this, low-grade histology, things look very bland under the microscope, and a horrible clinical course of rapid recurrences, which are difficult to treat. And I'm pretty sure there's going to be some subset of those patients that will find some sort of mutation that doesn't manifest itself through light microscopy, but we don't have it yet. So some of the patients, even though they're low grade, in general, I don't like to take people back for a second HIPEC in less than a year. They tend to do pretty poorly if we do. We've looked at that in some detail. But if it's all low grade and we're running out of, we don't have a whole lot of support available from systemic therapy, that's fine. I think before I went back a third time, I think I would have reached out to medical oncology. I would have pulled on Dr. Shen's sleeve and see if I could have cajoled him into a trial of systemic therapy, because it's behaving like a high grade, even though the histology is looking like a low grade. And I would certainly look at the clinical behavior. Again, I've been highlighting how important it is to get an expert opinion. Even the best pathologists, I think it's a limitation of the technology, not a limitation of the pathologist in terms of what they can tell you. And there's going to be some of these patients that are not going to behave like a low grade, even if that's what the final pathology report comes back as.
Yeah, no, I would agree with all of the comments. I think one of the other things that I'm sure we're going to discuss in our later part of our sessions today is the role of even NGS in some of these things. It's the genome sequencing, and sometimes when you look at these pathology, they'll often have common mutations like KRAS. But if you start seeing mutations that are SMAD4, SMAD2, some very aggressive PIK3CA, I think those types of mutations also, I think, makes me very reticent to going back for another surgery, in addition to all the other factors that Dr. Levine mentioned.
Great. Well, I think we're at the end of the time for the tumor board. I really want to give a huge shout out to Dr. Affolter and Dr. Olpin for putting together the slides and the images, and for taking the time to review these cases, and to try to present the discussion in a way that would be helpful for the audience. And so I really want to thank you guys, and Dr. Pai for your expertise as well, and to my other colleagues on the tumor board for your input. So I think we'll wrap this session up, and I think, Dr. Levine, it's a question and answer. Is that correct now?
Absolutely right. So I think we can move into some of the Q&A phase. I'd also like to thank all the members of the tumor board, and for people watching, what does a tumor board actually look like? This is what it looks like. Again, what you're seeing is a number of different doctors coming together with different expertise, all of which has to bear on the patient. And everyone has it's like a puzzle. Everyone has their own piece and their own role to play, and how we get them back to work together for the patient, to me, that's crucial. That's what these tumor boards are really all about. So to all the members of the tumor board today, thank you, particularly people for anonymizing the images and slides on the fly. You get absolutely a gold star for that. Thank you for that. So at this point, I think we can start moving into some of the questions, and there's a number of them which have come up. I think are going to relate to all the different areas of expertise. So let me see if I could find one here. Where to begin? I'll start out with the easy one. I want to hit this again in terms of the Bromac question. And Bromac is two drugs, which is bromelain and N-acetylcysteine, both of which are mucolytic agents. I'd love to tell you that it's going to be available. I'm still working with the people in Australia, Dr. Morris, who's come up with this. And to me, it's remarkable that an enzyme from a pineapple stem can be useful, but I think that's where we're going. But it's still not widely available. It is available if you're willing to go to Australia to get it. Before you took that trek, I'd put you in touch with Dr. Morris, who did it. We had one question which came in. I guess this is more for the clinicians and Dr. Shen. It's a patient who undergoes a hysterectomy and bilateral salpingo oophorectomy. At the time of surgery, she was premenopausal at the time. And now the question is, can she take hormone replacement therapy to ameliorate some of the postmenopausal symptoms? So I might kick this back to Dr. Lambert. How do you counsel people in that setting?
Good. So I actually am very willing to have women go on some low dose hormone replacement therapy, especially to get them through the initial period with the postmenopausal symptoms that can come on really bad after, putting somebody immediately into complete menopause surgically by taking out the ovaries. It's a huge physiologic change that can be very uncomfortable. So I'm fine, and I will often do it myself. I'll just put them on a low dose hormone replacement therapy for a period of time to get them through that initial phase, and then refer them to a gynecologist for longer term hormone replacement therapy if that's something they want to do. I would love to hear what Dr. Shen's thoughts are. I'm not aware of any direct impact of hormone replacement therapy on recurrence of appendiceal cancer.
Yeah, agree. As far as we know, appendiceal tumors are not driven by female hormone, unlike primary GYN tumors. So, they obviously, it's very common that you could be symptomatic if the ovaries are removed in a premenopausal woman. So I think that hormone replacement therapy definitely is appropriate.
All right. Let's go on to the next question. I think this is more of a pathology question. And this is relates to the primary tumor and the histology. So if someone has their appendix out and they undergo a cytoreduction and HIPEC, and the appendix is read out as a low-grade appendiceal cancer, but all of the metastases are only acellular mucin, how would you classify the pathology? Is this a low grade? Is it a high grade, or does it matter?
The primary is low grade. The peritoneal disease is entirely acellular. I mean, those, from what I understand, those patients have the best, outcome possible, because at least in terms of our sampling, we're not finding any cells in the peritoneal deposits, and that's a good thing. So it's a good question. We don't even grade it because there's no epithelium to grade. We just call the peritoneal disease acellular mucin with no epithelium to evaluate. When we do see that, we do go back and try to sample as much as possible to see if we can find epithelium. In some cases, we never do.
Okay, thank you. Let's see if there's another pathology question, which is if someone has a Levine tumor and appendiceal cancer in the same specimen, which one is it? Or can it be both?
If someone has a Levine tumor in the primary and appendiceal peritoneal
and cancer in the same appendix.
Oh, I see. Yeah. So at that point, once you arrive at a diagnosis of adenocarcinoma, the precursor lesion could resemble something that looks like a Levine or a Hammond, but the key is that adenocarcinoma is present, and that's going to be the most important thing to focus on, because at that point the appendiceal tumor is classified as an adenocarcinoma, potentially arising from a Levine or a Hammond. So we would classify it as overall as an adenocarcinoma.
Thank you. Another question, I'll just throw that out to the group. Is there an effect of pregnancy on the progression of Levine or appendiceal cancer? A patient had what looked like explosive growth, is how it's described, a few months after having a child. Does anyone have any insight into the influences of the hormones of pregnancy on tumor progression? Personally, I do not.
Yeah, I'm not aware of that's been studied either.
I don't either, but I do have an anecdotal experience of a young woman who got pregnant shortly after her diagnosis, and the disease seemed to on? Like it's one of those cases that has just stuck with me. I don't have an explanation for it. So I'm intrigued by this question and this comment.
All right, here's another question that comes in. Someone had presented with a mass in the abdomen. The biopsy comes back just acellular mucin. Can you base the recommendation for a cytoreduction HIPEC on that? Do you have to have cells in it to know where it's from? Or can you accept mucin only as an indication to move forward with surgery? Let me pick on Dr. Taraga to help us with this one. You're muted, Karen.
And do you mind just kind of giving the context again one more time? So big mass in the abdomen and...
So there's a mass in the abdomen and they get a biopsy and it comes back just acellular mucin from the mass. Is that enough to move forward with a cytoreduction HIPEC, or do you need another biopsy?
I think it's based a little bit on the clinical context, right? Like I think if it is one mass and let's say the rest of the abdomen does not have anything concerning, there's no nodular features, it looks consistent with like a PMP grade 1, then often I would approach something like that with a diagnostic laparoscopy and then proceed with surgery to take out that acellular mucin mass, whether it's in the appendix or metastases. If the biopsy was done properly with image guidance and there weren't sort of these nodules or things that were missed, then I don't find the value in repeating biopsies for these masses which have acellular mucin.
Dr. Lambert, do you agree with that?
Yeah, I do. Yeah, that would be the same. Might would have the same thoughts.
Okay. So another question that comes in, and I get this question a lot. All these patients after they undergo therapy, surgery, treatment, need follow-up. Are you better off with MRI or a CT scan for long-term follow-up? And this has been an area of controversy, certainly amongst many of us. So let me ask the radiologist to see if they can chime in and help us out.
Well, I think that CT is definitely the workhorse of abdominal imaging. The advantage of CT is that it's much more cost effective than MRI. When we perform MRI, well, let me go back. When we perform CT, it's easy to go from the lung bases all the way down to the top of the legs very quickly and efficiently. We can do that literally in 15 to 20 seconds. We can obtain those images. MRI, when we perform an abdomen, it does not include the entire abdomen and pelvis. That's a separate order. So already you have to place an order for two different studies that are significantly more expensive. So the quick and dirty answer is that CT is definitely the workhorse. It gives you the 30,000-foot view of the abdomen and pelvis in a very cost-effective and efficient manner. There are those that have suggested that maybe MR plays some role. There are some techniques specifically called diffusion weighted imaging, which is a fancy term for just saying that they can look at the tissue's maybe metabolic activity and see if it's active or not. That's still a little bit investigational. I don't think it's been widely validated in the clinical arena for using MR in these instances when we're looking for widespread neoplastic processes in the abdomen. So long story short, CT, I think, will always be kind of the workhorse.
Dr. Levine, I guess I would just add to, from my personal perspective as a surgeon, I find reading CT scans a lot easier. I don't know about you guys, maybe Ed and Karen, maybe you guys are really good at reading MRI, but I think CT scans give us more the information that we need for surgery, and most surgeons are going to be more comfortable reading a CT scan of the abdomen than an MRI of the abdomen and pelvis. I think some of the concerns, Dr. Open, that patients and their families have, if they're going to be getting CT scans for a long period of time, like we're following patients out 10 years, the risk of the radiation. I'm sure you get asked that question a lot as well. What are your thoughts on that?
So that is a concern. Over the course of a patient's lifetime, I don't know what the maximum number of CTs you've seen in the clinical arena. More than 10, perhaps. I mean, that is a concern, and we could definitely use MRI in those instances. MRI in the setting of inflammatory bowel disease has made a big splash because we feel like that patient population with things like ulcerative colitis or Crohn's disease, those folks are going to get imaged many, many times, maybe every other month over the course of many decades. So because of that, we've developed techniques specifically called MR enterography to look at the bowel that way, just for that very purpose, so that we're not irradiating these people over and over again. I've never heard in the literature it being used serially in this clinical scenario. I guess it could be. These are more rare than probably inflammatory bowel disease, and so I just don't know if it plays a role at other institutions. At ours, we don't use a lot of it, to my knowledge.
Oh, we don't. Mm-mm.
All right, so next question. I think this is an easy one. I might just handle. How relevant is a diagnosis of adenocarcinoma determined by the surgeon during the surgery versus the final pathology report, which stated the tumor turned out to be a Hammond tumor? And I will tell you that after doing a large number of these procedures, you can't always tell by looking at it or holding your hand with 100% certainty. If you could, we wouldn't need pathologists as much as we do. So it might be the surgeon's impression that it was cancer when they looked at it, but I think you have to rely on what the pathologist tells us. So I think that's sort of an easy question, unless anybody else wants to chime in on that one. Here's another question that comes in. This is a patient who has what they call MSI high or microsatellite instability high, and they had a poorly differentiated, sometimes called signet ring cancer. What's that implications of that in terms of systemic therapy? And I think it's a question for Dr. Shen.
Yeah, so MSI high is relatively rare in appendix cancer. We found maybe only about 3% versus maybe 10% in colon cancer. But generally, the MSI high tumors are tumors that respond very well to immune therapy. So I think you'd want to confirm that the mutational burden is high. But if that is the case, those tumors, are very likely to respond to immune therapy. And so there are kind of tumor agnostic immune therapies that are approved, or you would be able to get access to immune therapy for colon cancer, or ideally a clinical trial of immune therapy. But definitely would go with an immune therapy in that situation, because signet ring tumors generally don't have a great outcome with traditional chemo.
Okay.
I was going to make one comment though, that sometimes pathologists, when they look at the pathology report, they'll say there's mucinous features with signet ring cell, and may suggest an MSI high tumor. That's not the same as having an MSI high tumor. I don't know, Dr. Pai or Dr. Affolter, if you wanted to elaborate on that.
Yeah, sure. So in the colon, mucinous features or signet ring cell is associated with a higher rate of MSI high. But in the appendix, the rate of MSI high is so low. In fact, if I saw one that's a signet ring cell MSI high tumor, I'd be, I'd think, is this a cecal primary or versus an appendiceal primary? Would be going through, thoughts in my head. Cecal being colon primary.
Yeah, you can confirm that if you do NGS next generation sequencing, you'll see a very high tumor mutation burden. In addition to the IHC that shows you the loss of the one of the 4 proteins. Like if that's the case, whether it's the cecal primary or appendiceal primary, the MSI high tumors generally respond very well to immune therapy.
I'll say a lot of these rare things that we're talking about today, it's really nice to have more than one laboratory test that suggests it's real, right? So that mismatch repair by IHC would be one way to look at that. There's also a PCR test that looks for instability, or like the NGS, where they do a tumor mutation burden, also known as a TMB. Those are kind of 3 different ways to make sure this is a real finding.
All right. Next question is, what's the latest on follow-up? Forever, 20 years, 10 years? How many is enough? Dr. Lambert, what do you think?
Yeah, I think that's a great question. There was a submitted question about from a person who was diagnosed 42 years ago, who's had multiple surgeries and was asking if there's any role for chemotherapy or radiation, because he's been told or she's been told that there's no more role for surgery. It's a great question. I mean, at this point, what I do, not based on any data, is I follow people out to 10 years. We know that the likelihood of it coming back, the further out you get from the diagnosis, it diminishes significantly. So I follow people for 10 years, and then I just tell them that, I think it's less likely that it's going to come back than it's less likely that it's going to come back than it will come back, but that they need to be aware that it can still come back 20, 30 years later. And so if they are seen for another reason, they get imaging, they want to make sure people are aware of this as part of their history, so that if people see something on a CT scan, or they'll look specifically to see if there's any concerns for recurrence even 15, 20 years later.
Dr. Shen, is there a medical oncology approach to this question?
Honestly, really, I saw that question in the chat. We're trying to review our internal data to kind of get better stats on what, what is the percentage that happen after 5 years. I agree that I think that it makes sense to follow people out to 10 years, just because with low-grade tumors, you can have late relapse. And interestingly, we've seen with goblet cell tumors that you can have a very late relapse. In colon cancer world, we're generally taught to stop after 5 years, but I think continuing with like a yearly scan to 10 years makes sense. Hopefully we'll have new data on that to update, but I wouldn't, after 5 years, I wouldn't do any more frequently than a year follow-up, but there are people that recur in that 5 to 10 year space.
I usually do every other year after 5 years. But it comes back to, Ed, to your point that appendix cancer is not colon cancer. I mean, we've heard that from every aspect here now, like how we should follow them, what the histology and what the different markers that we're looking at, the genomics are totally different, the behavior is totally different. So I think that point just keeps coming up no matter what context we're talking about it in.
All right. Let's see.
It looks like it's time for a break.
Yeah, I tell you what, I'd like to thank all the people who sent in questions. We'll try to answer as many of them as we can. We're going to take a break at this point for lunch. So I'd like to thank everyone on the call, everybody who took the questions. Thank you, everyone, for the Tumor Board. Thanks for dialing in. We're going to be planning on coming back at 12:25, which is just 18 minutes from now. So we have some time for lunch to move on to the next segment of the day.